Hi, I'm Shelley Wood, the managing editor at TCTMD, and this is On Record, a regular program looking at hot topics in cardiology and beyond. My guests today are Dr. Vinod Thourani, Dr. Milind Desai, and Dr. Coylewright. And our topic is aortic stenosis. I have a surgeon, a cardiologist, and an interventionalist to help us with some of this. It has been an area where we have had some heated discussion, I will say, from the journalistic perspective. Certainly journalism loves debate. And there has been this in the surgery and cardiology fields, but at the center of all of this is the patient with aortic stenosis. I'm curious to hear from the three of you, given all of the trials that we've seen in recent years, the unknowns, how do we make sense of this, and what do you tell your patients when they're trying to make decisions on medical therapy, on surgery, on the transcatheter valve? Dr. Thourani, do you want to tell me? Where do you go with this?
Start with the surgeon, that's okay.
Exactly. The surgeons like to go first.
So I think that, I kind of still break it up into low, intermediate, and high-risk patients.
Sure.
And we're seeing these together with our cardiologists. So Pradeep Yadav and Vivek Rajgopal and I see a lot of the patients coming through the Heart Institute. And once we do differentiate the high-risk, intermediate, and low-risk, the high-risk patients are relatively easy. The extreme risk are relatively easy. The high-spectrum patients in the intermediate risk category are relatively easy. They all go towards the transcatheter valve therapies.
Sure.
The low, intermediate, and the low-risk patients, we have a long, robust discussion with them. I like the word robust because it's neither surgical or it's neither cardiology. In those patients, we talk to them about data that's been currently published in the sense that intermediate risk patients with Partner 2 and Surtavi, which we'll see some results from 5-year at Surtavi here at ACC coming up, show that most likely, at least in Partner 2, that 5 years there was equivalence between the two therapies. And so we feel very confident in telling patients you can choose either procedure. We believe that your early quality of life is easier with transcatheter valve, so we most likely go into the transcatheter valve patients with those. In the low-risk patients, non-bicuspid, trileaflet patients, we're more likely to say we only have 2-year data. Yeah. So we believe if the 2-year data acts like the 5-year or the potential 10-year data, we feel comfortable doing transcatheter valve therapy as the first mode of therapy for those patients in the low-risk category. But we do tell them that we only have 2-year data, and we still need to follow these patients for 5 and 10 years before we can make that conclusive decision with them.
Right.
So that's how we're relatively balanced, and I'm hoping that the other 790 sites do a very balanced discussion, because that's what we owe, Shelley, like you said, to the patients.
Yep.
It's about patients in the middle,
sure,
not about what I want or what Megan wants.
Well, I was going to say, Dr. Coylewright, I mean, for you are perhaps for every physician, I would say, that again, to bring it back to the news stories, we do kind of emphasize this, but you might feel better sooner, because we've heard that patients are going in with news articles to their doctors to say, can't I have this? So how do you explain those nuances to your patients?
Well, I think it's really important to put patients' values and preferences at the center of the discussion. And finding out what's most important to patients is actually relatively difficult. We haven't necessarily been trained in all of the different sociodemographic groups of our patients, many of whom don't look like us or have similar background to us. Understanding what's most important to them is challenging. And so we can explain all the risks and benefits, but really seeing the patient as expert and listening of what's most important to them. And for most people, they don't come in saying, my value is I want a TAVR.
Sure.
They want to feel better, to do certain activities. They have goals for the future. They may value longer life. Mm-hmm. Others may value certain activities. Yeah. So it is important for each patient to be able to feel that they have a place at the table. But what we found over the last decade as we've worked to implement shared decision-making is it's been harder than we thought it would within the cardiology and cardiac surgery community. So we are developing a lot of tools that are available through the American College of Cardiology patient engagement project, which is called CardioSmart and Patient Voice Team. So we have decision aids available for the low, intermediate, and high-risk patients to help them feel invited to share what's most important to them in that clinical encounter.
Yeah, not intimidated by it and all those things. Dr. Desai, we were talking about shared patient decision-making, that whole balance before we started taping, and I asked you the question of, is there a way that you can also bring the prevention angle into it? Because, I mean, ideally you could stop aortic stenosis from developing in the first place and give these guys a little less work. But is that something that patients are interested in hearing about? Or, I mean, the tools aren't necessarily there
Well, I mean, thank you very much, Shelley. So the big picture is majority of the times by the time a cardiologist gets involved in this patient with aortic stenosis care, the ship has sailed, and prevention is, we don't have really effective tools of prevention just yet. What you are referring to are these newer therapies that modulate lipoprotein A, and which has some mechanistic insights in the pathogenesis of aortic stenosis. If you can modulate it upstream, we can potentially slow down or prevent aortic stenosis. Yes, there's some conversation, but that is still years away.
That's not going to help in a heart team discussion at this point.
No, but I was listening to two of my esteemed colleagues once, and one likes to play with catheters, one likes to play with catheters and knives. The important thing is, it is good that there is controversy or robust discussion, because a family that does not have any communication, if they're all at dinner table, is a family that's not going to stay close together. So it is absolutely important to have conversations.
Robust discussion.
Robust discussions. And that's how consensus evolves. That's how opinions evolve. That's how ideas evolve. And, as a non-interventional cardiologist evaluating the patient, so that's one aspect of communication as part of the heart team that has been discussed. But the communication, you try to be the patient advocate. You are communicating with the patient. This is the lay of the land. This is the data. They don't care about partner 25 and CERTAVI 32. They want to get my 30-second summary of what would you do to your family member. So more and more, I am now finding myself, the low risk, high risk, intermediate risk, it's where they are in their station in life. What is their age demographic? Now I'm like, if you come to a place like the Cleveland Clinic or many of the experience centers, your reoperation rate from a cardiac surgery is pretty low. Your TAVR rate, mortality rate is low. So I am more and more about, let's plan. This is like your 401A, like 401k, 401A.
Yep.
You are a 50-year-old or 55-year-old person. If assuming you live to be 85, 90, you may, let's talk about lifelong management of your,
right.
You may be a TAVR, SAVR, TAVR candidate. You may be a SAVR, TAVR candidate.
Right.
It is about
You're
having
talking about
everybody
getting the
in the
patient
tent.
into not just the decision for today, the decision for
Exactly.
your current
And
lifestyle, but also for 10 years down the road.
And as a non-proceduralist, one of my pet peeves is, or I'm try to be effective with the patient, but also pass the message on to my colleagues, is I don't want to see a patient back in 6 months with a size 21 valve or a size 19 valve and a patient prosthesis mismatch or whatever. Please make sure you give this person, if you're doing a SAVR as a first approach, please give them a fighting chance to get a valve-in-valve TAVR
down the road.
downstream. And just don't do a TAVR because you can, and if the right thing is to do a SAVR. So it's family communication.
Well,
this is family.
Yeah, and we certainly have had. I could see Dr. Thourani was trying to jump in there too, because there's a lot we do not know about TAVR valves. 10 years down the road, let's say. But I will also have the interventionalist telling me that we actually don't necessarily have the same quality studies at baseline for the surgery devices of the past.
Yeah, I think that the most studies that we have on surgical patients are actually within the randomized trials that we've done through Partner and the core valve trials.
And
but Megan, I have a question for you. So sometimes patients come to me and they say, I want to feel better sooner. I've got X, Y, and Z. I've got a trip coming up. I've got a big business meeting coming up. But we know probably this is a bicuspid valve that has some aortic root calcification, that we're not going to give them potentially the best outcome of the TAVR. So sometimes it's a discrepancy between shared decision-making, what the patient wants, what we think is medically not the right thing to do. How do you balance that?
Yeah.
I think you bring up a good point, and that is shared decision-making is not appropriate for all decisions. Mm-hmm. It's when there are two comparable options that differ in their risks and benefits that different patients weigh based on their own, where they are in life. If you have a patient who is not going to do well with TAVR, you don't have equipoise anymore.
That's exactly
That's where
right.
we provide advice as the medical
Sure.
professionals. But there are a lot of times where both options would be reasonable for different reasons. And I think, I love what you said about thinking when the patient says to you, what would you do if I were
Yeah.
your family member? And really what they're asking us is, know me as you know your family member.
What can I tell you that will help you make the best decision
Exactly.
for me?
We have to listen to what's important to them and get to know them. And that is challenging in short periods of time. That can be helped with some tools, but really that can help inform our decision when there is a choice between
Right.
two reasonable options. So we do say, as
That's right.
I know all of you do, we sit down and say at the beginning of the conversation before we have the CAT scan, we don't know yet.
Yeah.
What are the appropriate
Absolutely.
choices to choose from? We'll
Sure.
find that out, and when we come to that time, that's when we'll engage. That's where I worry a little bit about how we've deployed the heart team over this last decade. I had a patient come to me recently who said, I'm coming to you for a second opinion because at the last center I was at, they all went away to a different room on a
Right.
different day and made a decision, and then had a nurse call me and tell me what the decision was. I wasn't included in that.
Yeah.
So we have kind of hidden ourselves away in conference rooms. We're so distracted by all the details. We have to bring that back to the patients
Right.
when there's equipoise.
And that
to
when you
include
have
them.
this chorus of voices, you do in the end need the patient's voice to be a part of it.
That's exactly right.
I have a question. How, perhaps there is data, how often does the heart team conversation happen with the patient in the room? I don't think it happens as often as people think it does.
You know what I should do next time is I should have the patient join my panel. We
that's
need
right.
one more chair.
That's right.
You know, there's so many other things, aspects of this we could talk about. And I was going to say that as much as I wrote about the heart team, I think in the first 10 years of TAVI, more and more now, it is about patient-centered decision making. And I can hear it in everything you're saying. So we'll save a chair for next time for a patient perhaps. But thanks all three of you for taking time to tell me about this today.
Thank you so much.
Thank you.
Thank you.
And thank you for watching On Record.